Going to talk about nerve injury from peripheral nerve blocks, nerve injury that arises during general anaesthesia and specifically from patient positioning, and a little bit of detail about NAP8 because that's very much on the horizon. I'm not going to talk about nerve injury arising from central neuraxial blocks, although that is going to form part of NAP8, which I'll mention at the end. That's a kind of topic for another day. So I know it's slightly tedious to start with some anatomy, but I think some of the terminology that gets used when we're talking about peripheral nerve blockade and where we're aiming our needle tip is very important. So just as a kind of reminder, that's a cross-section of a spinal nerve. The whole nerve is surrounded by epineurium. That's the kind of loose connective tissue that contains the vasa nervorum, the blood supply to the overall nerve. And generally speaking, we want to aim our needle tip for peripheral nerve blocks extraneurally. We want to be outside the epineurium. One of the problems, though, with ultrasound machines, even the best ultrasound machines on the market, don't really tell us exactly where the epineurium begins and ends. What we definitely want to avoid is breaching or damaging the perineurium. So that surrounds individual nerve fascicles. That's the most important homeostatic kind of barrier that controls the electrolytes and the environment around individual axons. So nerve damage to fascicles is certainly a bad thing. Individual axons are then surrounded by endoneurium. Luckily, in human peripheral nerve anatomy, it's actually very difficult to penetrate and damage individual human nerve fascicles unless you're very close to the neuraxis. There's only really blocks like an interscalene block where you're looking at nerve roots, which are themselves entire fascicles, basically. Then you are able to use a short bevel block needle, cause damage through the perineurium and into the fascicle. But actually, people like Graham McLeod, a researcher up in Dundee, have shown it's otherwise remarkably difficult to damage individual human nerve fascicles, which is good for us as clinicians doing these blocks, because as I say, with modern ultrasound, sometimes really delineate exactly where fascicles or epineurium begin and end. You might hear sometimes in the literature people talk about intraneural needling or subepineurial needling. That's putting your needle under the epineurium but between fascicles. We shouldn't deliberately do that, although it has in the past, it's had its advocates. But we do sometimes observe that. So if you do a nerve block and you can sometimes see the nerve expanding as a result of the introduction of your local anesthetic, well, that might well be a subepineurial injection or an intraneural injection. And you should stop injecting, withdraw your needle, and attempt to reposition the needle tip. But luckily, we seem to get away with that because that doesn't breach that perineurial layer. Brief bit of anatomy, and then even more tedious, the Seddon classification. This has been around since after the war, but these terms do get used by neurology colleagues and in neurophysiology reports. So again, just as a kind of reminder, in descending order of sort of severity of injury, neuropraxia is a kind of temporary stunning of the nerve. There may be some disruption to the myelin sheath, but that is likely to be temporary. I think about that as, if we fall asleep and wake up with because we've slept in a funny position and our arm, say, has gone dead, then we're experiencing a very temporary neuropraxia there. An axonotemesis and then neurotemesis are more severe. Axonotemesis probably does involve some damage to the perineurium, and recovery is variable, and it may take weeks or months from that kind of injury. And then the bottom on that neurotemesis, there's complete transection of the nerve. So the endoneurium is also transected, and two nerve ends are no longer in apposition. And potentially, unless that injury goes to a nerve surgeon in order to reoppose the ends of that peripheral nerve to facilitate axonal regeneration, then potentially that is a permanent loss of function for that peripheral nerve. One of the key things, if you're seeing someone with neurological abnormalities kind of after a peripheral nerve block or after a GA, is to try and figure out, well, am I dealing with a neuropraxia here, or is this something more severe? Is this a neurotemesis that actually needs to be reviewed by a nerve surgeon? I'll talk about that in a sec. Now, this is data from Tim Cook, published in Anaesthesia a couple of years ago, looking at cases sent to NHS resolution in our specialty. So these are just NHS cases and the proportion of NHS resolution exposure to different subspecialties. You can see regional anaesthesia actually the number one litigation-related kind of activity for NHS resolution, and patient positioning injuries, of which nerve will be some of them, is in there as well. But we've got to remember that overall, certainly compared to our emergency medicine colleagues on labour suite and surgical colleagues, anaesthesia is a kind of order of magnitude less exposed to litigation in comparison to those specialties. So obviously that's very reassuring. Let's just talk a little bit about that nerve injury due to peripheral nerve blockade. I suppose the headline for this, in terms of incidence and epidemiology, Michael Barrington showed over 10 years ago now from a big Australasian database of nerve blocks conducted in Australia. If you see a neurological abnormality after peripheral nerve blockade in a patient who's undergone surgery or with a general anaesthetic, about 9 times more likely to be related to some sort of surgical or patient factors than to a block. That's a kind of headline reassurance, I suppose. The risk of permanent injury after block is very, very low. There's this phenomenon called postoperative neurological symptoms, PONS. That's very common if you go looking for it. So patients quite often after peripheral nerve blockade may have slightly abnormal neurology in the block distribution or in the blocked limb in the first week or so after surgery. If you go looking for it, about 10% of patients, they might have little bits of residual paresthesia or block that's prolonged beyond the effect that we would expect from a local anaesthetic. We don't hear about all of those. These patients, we don't routinely follow them up in Nottingham, but they are there. And the good thing is that most of those patients with those sort of residual post-operative neurological symptoms just improve over time. And patients, because they've undergone surgery, often don't even realise they're there. Risk of permanent nerve injury, and the nerve surgeons will often use 6 months as the cut-off of when an injury is likely to be permanent, is often quoted between 2.5 and about 7,000. So 1 in 2.5 or 7,000 is ASRA data from the American Society that was published about 10 years ago. That's probably why our Royal College information leaflet went for about 1 in 5,000 as the risk of permanent nerve injury after peripheral blockade. I'll talk about local data, which I think is also important for sort of consent purposes in a little bit. If you suspect that a nerve injury might be sustained from peripheral nerve block, then there's 3 main mechanisms by which that might occur. You might have direct needle to nerve trauma. And as I mentioned, that's reassuringly difficult to do in most of the peripheral nervous system, but is possible and is more likely the closer to the neuroaxis you are. So that might be one reason, amongst others, that interscalene blockade was traditionally cited as having a higher risk of nerve injury. You might cause direct needle trauma. There could be compressive hematoma or some form of disruption to the normal blood supply around the nerve from your nerve block. Or there could be a chemical injury, potentially due to something like drug error, but also additive. We're just going to go through these in a little bit more detail and really what we do to avoid them. Obviously, the fundamental kind of maxim of ultrasound-guided regional anaesthesia is to aim for extraneural needling. We want to stay outside the epineurium if possible. There's that meticulous visualization of your needle tip. That's taught from the first stage of training in order to make sure that we don't cause nerve injury. It is the default of many or most of us, I think, locally to do blocks awake if we're able, but actually it's perfectly acceptable to do blocks under general anaesthesia. I think it's worthwhile just documenting the reason that you're doing that. It's difficult to avoid the fact, though, that elicited paresthesia, the patient says ow in response to some needling near a nerve, is still quite a useful warning sign of potential nerve impingement. And it's not the most sensitive or specific sign. You can elicit it without being near the nerve, but actually my default is to perform the blocks awake, and I think that speaks for most of the colleagues that are doing blocks in Nottingham. And then there's the fundamental thing of just staying within your own competence, really. Ask for help from colleagues if you're being asked to perform a block that you're not as familiar with, the use of nerve stimulation, it still has a role in deep blocks where you're maybe not able to visualize nerve anatomy very well on ultrasound, and there is still a role for using ultrasound with nerve stimulation. In terms of compressive hematoma and the vascular disruption, this sort of touches on anticoagulation and peripheral nerve blockade. There's no hard and fast guidance that's sort of internationally or nationally applied to this. Pragmatically, I think most of us will be thinking in an anticoagulated patient or a patient with abnormalities of coagulation, if a hematoma did occur due to the nerve block, the fundamental question is that hematoma going to threaten the nerves? Is the block being performed in an area where the hematoma will be compressible by external pressure, somewhere like the popliteal fossa? That's pretty readily accessible for me. If there is a hematoma occurring, to apply some external pressure to prevent hematoma expansion. And then if the hematoma does expand, is the space itself kind of non-expansile in a way? So again, I guess the pop fossa or the axilla, there's generally room there for a hematoma to expand before it will cause any disruption to the nerve vasculature. That's kind of reassuring to perform blocks in relatively anticoagulated patients, in contrast with, the lumbar plexus or a sci-fi block where you're trying to put local quite near areas of the body in the pelvic brim that are not essentially non-compressible externally and also relatively non-expansile spaces. And then finally, chemical injury. As a broad rule of thumb, we don't use very many perineural adjuncts at all, apart from adrenaline. You've got to be very careful with any kind of perineural adjuncts that they don't contain neurotoxins and preservatives, which are going to cause neurolysis. There's very little benefit or there's no benefit, I think we can safely say, to perineural versus systemic dexamethasone, and it always risks those preservatives causing neurolysis. I mean, basically avoid adjuncts. Some practitioners also avoid adrenaline-containing solutions in people with known neuropathies or diabetes because of concern about affecting the nerve blood supply. NR-FIT has obviously been instituted across peripheral nerve blocks in Nottingham, so that is a mechanism by which we can avoid drug error. And then as a broad principle, to try and use the lowest possible dose of local anaesthetic, I think is very useful. Local anaesthetics, even in clinically relevant doses, do display evidence of neurotoxicity. So just think about what it is that you want your block to achieve. If it's an analgesic block just designed to be opioid sparing, very reasonable to use lower volumes and lower concentrations of local anaesthetic to achieve that. And of course, ultrasound allows us to do that. Perhaps that's different if you need your block to be anaesthetic, in which case potentially slightly higher volumes and or concentrations of drug are needed. But the reason to avoid, to always choose the lowest drug dose, possible, is, as I say, because local anaesthetics are neurotoxic. This is a paper from a decade ago now by Elizabeth Whitlock. It's a rat sciatic nerve, but this has been similar work has been done in humans. But the top there, that's the rat sciatic nerve exposed, magnified under saline. That's normal nerve anatomy under 40 and then 400 magnification. Panel B is the same with exposure to phenol. You can see on the right there's just disruption of the normal nerve axonal architecture and kind of periaxonal edema. And then C there is in exposure to ropivacaine 0.75. So that is a local anaesthetic in our drug cupboards. Actually, that's extraneurally exposed. So that's putting the local outside the fascicle still results in quite marked kind of histological abnormality. So it's no wonder that 1 in 10 patients might well experience some funny paresthesia or slight ongoing abnormalities after a peripheral nerve blockade, luckily of no long-term consequence whatsoever. So this is maybe just teaching Granny to suck eggs a little bit, but in terms of protection against complaint or, at the most severe end, clinical negligence claim or something, Consent is obviously permission to proceed. We need to explain the nature of the procedure, which I think we usually do very well in peripheral nerve blockade, intended benefits, material risks, which I'll come to, and then something that sometimes isn't perhaps documented quite as well is whether we've explained to patients alternatives, including doing nothing. We can offer recommendations when it comes to consenting patients. So I might well say to a patient, if I was having this surgery, I would have this particular nerve block, or potentially I don't think it's necessary for this operation. But that recommendation just needs to be non-coercive, of course. So material risk disclosure, I thought this was interesting from Matt Wiles a couple of years ago, former Nottingham sort of colleague. He wouldn't have an upper limb block personally. His risk with GA is tiny, and if he has a neuropraxia, she says is much higher than his mortality risk with GA, he might have to stop working as an anaesthetist. Important that consent covers what he's describing as patient-centered outcomes. Consent must pay respect to what Matt is saying here, and it doesn't matter whether the Matt's reasoning for that or whether Matt is correct in his assumptions there, but we need to respect his wishes. The discussion for materiality needs to be tailored to the individual patient. And if the patient expresses no particular wishes, then we just need to judge on the spot what a reasonable person in that patient's position would want to know about that block. And people sometimes talk, don't they, about a granny test. If your granny was coming in for this procedure, what would you want her to know about the particular therapy that's on offer? So the granny test might be useful to people. Communication of frequency of risk is really difficult, whether we use words like uncommon or rare, or whether we're better off talking about 1 in 100 or 1 in 1,000. Pros and cons to all of that. But we should cite local or preferably personal data in preference to kind of national or international data. So although our Royal College says 1 in 5,000 risk, in reality in Nottingham we do between maybe 7,000 and 8,000 blocks, peripheral nerve blocks, a year. I think in the past decade, there's only been one case of permanent nerve injury, which has been kind of certain, or with a high degree of certainty, been ascribed to the nerve block. There might be other cases where the nerve block may have been contributory, but actually we're talking about an incidence locally of certainly an order of magnitude less than 1 in 5,000, certainly less than 1 in 8,000, and actually might be much closer to 1 in 80,000. And it's very reasonable to disclose that to patients. Obviously, we've just been talking about this form that's undergoing a bit of a refresh, thanks to George and colleagues. This is a great way to capture what it is that we're talking about patients. The only things that I tend to add are the intended benefit of the nerve block. So that's pretty obvious. It's just analgesia for day 0 or maybe into day 1, and maybe opioid sparing. So I tend to just write those phrases. And then importantly, the alternatives, including doing nothing. I mean, the reality is that no one dies through not having a peripheral nerve block, usually. And most of the blocks that we're offering are, from an external perspective, entirely optional. So I think it's important to disclose that. If the block is an optional opioid sparing, there is a reasonable alternative, which might be opioids. Maybe we think they're not as good as having a nerve block, but actually it is still a reasonable alternative. We need to just disclose that to the patient and document that. And the front of this chart just gives maybe an opportunity to write down some pre-existing deficits, if there are any, the diabetic patient or someone with peripheral neuropathy. Again, we've got a really good pro forma, don't we? This is a great way to capture what it is that we're doing for the procedure. Many of us sort of annotate this with a bit of extra information. The only thing that I do routinely document is some sort of acknowledgement that I've been able to reliably visualize the needle tip and the nerve architecture throughout the block. So I tend to add that in as an indication that I was happy with my needle visualization. So just moving on to the presentation, if you're faced with a patient with neurological abnormality after GA or a nerve block in this case, the key thing here is this someone with a temporary neuropraxia who has those sort of post-operative neurological symptoms that are just going to get better by themselves? Or is this someone with something more worrying that might need urgent treatment? That might be motor or worsening sensory deficit. is persisting well beyond the effects we would expect from kind of a local anaesthetic, so beyond 48 hours. One of the issues here is obviously these patients don't usually just come straight back to the anaesthetist that was treating them. They might come through all sorts of other routes, particularly surgeons, and I've noticed physiotherapists as well if the patient has been admitted as an inpatient. And obviously it can be very difficult if first clinicians to review the patient have disclosed nerve blockade as a potential mechanism, or have even said that that is the mechanism. It can then be, quite hard work to undo some of that initial communication. It's very important that we try and do so. This is the bottom of the RAUK algorithm for how to assess the early steps of management if you call to a patient, who has, say, a sensory abnormality or a motor abnormality after peripheral nerve blockade. This is just the bottom half of that algorithm. I guess there isn't time to go through it in any detail. It's very straightforward, I think, to use. It's available. And I think this should be the kind of go-to Google search if you are called to see a patient with a neurological abnormality. I mean, the key thing is if they have motor function or progressive sensory deficit, and that might be an urgent lesion which needs to be assessed face-to-face by one of us and or a surgeon, and then you need to consider whether they need an MRI or perhaps a re-ultrasound where the block was performed to see if there is a hematoma causing compression that needs release. It might be that they have a compartment syndrome. They might have a bone fragment or a plate from surgery which is causing nerve compression that again needs to be released. Or they might have something really simple like a plaster of Paris cast or a sling, which again is something which needs to be urgently released. If it's a non-urgent lesion, so there isn't a motor deficit, the symptoms are not progressive or painful, that might be a non-urgent lesion. Again, there might be block causes to that, or it could be surgery related. But because it's a non-urgent lesion, there's slightly less urgency to get things like an MRI looking for a hematoma. But we still need to follow those patients up. May have to consider referral to neurology and nerve conduction studies. So this algorithm, I guess the key message is really just this algorithm is available to have a look at online. Just to close things up, because I'm aware of time and coffee, nerve injury due to patient position under anaesthesia, I've called it there, because it's not necessarily under general anaesthesia. If you look in the literature, virtually every nerve in the human body has been described as being injured due to patient positioning under anaesthesia. I'm just going to mention brachial plexus injury and ulnar nerve injury because they're the most common in kind of adult non-cardiac practice. There are certain high-risk positions, I think, for these sort of injuries. Definitely the cruciform position, so bilateral arm boards, lithotomy, lateral positions, and all the kind of variations and different lateral positionings that we do with the arms and the legs. And then similarly, prone positioning and all of the different variants, whether the arms are down by the side, whether the arms are up above the shoulders with the shoulders abducted. And there's also some known risk factors in terms of underlying patient conditions that will make a position-related nerve injury more common under general anaesthesia. If you've got a patient who is malnourished, who is perhaps beyond the 5th or 6th decade of life, has diabetes, may have either a known or an underlying sensory peripheral neuropathy, who's undergoing a long procedure in the prone position or in a cruciform position through surgical necessity, who might sustain some intraoperative hypotension or anemia, then I think it's very reasonable to disclose to that kind of patient that general anaesthesia is associated with risk of position-related nerve injury. It's clearly not routine to disclose position-related nerve injury patients without those sort of risk factors or in high-risk positions. But we know that these can cause problems, these underlying factors. Post-operative ulnar neuropathy is actually very rare when it's reported to us. So probably only 1 in 10 or 15,000 GAs will be associated with it. And it tends to be men beyond the 6th decade of life, often with underlying, about 85% of them actually have an underlying neuropathy on the contralateral side. Interesting, if you go looking for it, like with many of these things, if you were to look at patients in the recovery period, elicit symptoms from them and do nerve studies on them, so you actually just go when looking for it, the incidence is about 1 in 280 or 1 in 300 have some degree of vulvar neuropathy. Again, these are patients that have undergone surgery. Neuropathy is temporary, is not reported back to us, of course, and so there's this sort of underlying, we're just seeing the tip of the iceberg of the pathology. Even at 1 in 14,000, though, if we're doing 50,000 GAs a year, perhaps in NUH, then that's 5 a year or so, which again, interestingly, aren't coming back to us as in anaesthetics routinely. Steps to avoid this. These are largely from the an ASRA practice advisory that was published a few years ago. These are just kind of largely expert opinion. There's no huge degree of evidence base to support most of these, although there is some underlying kind of physiological evidence. You want to try and avoid elbow flexion across the chest. I know that's the favoured position for lots of gynae and urological procedures. I'm happy to kind of tolerate it for a short procedure, but arms flexed and sort of tucked under the gown, the cubital tunnel then is just potentially lying on the side of the bed. If there's more than 30 minutes, that's really not a good idea, particularly if it's an elderly gentleman. If you've got the arms either by the side or on arm boards, probably a neutral forearm position is best, so not pronated, and supination may be better, but neutral is probably the safest. Of course, routine kind of padding in modern theatres with gel pads and things, the elbow. Avoiding blood pressure cuffs and other devices over the cubital tunnel is a good idea, particularly now we're measuring blood pressures often every 2 minutes. And then intermittent checking of position. Again, this is just for high-risk cases. If I've got a diabetic who's going to be prone with their arms above their head, prone position, or a couple of hours having a multi-level lumbar decompression or something, and I think I will routinely, just every half an hour, I just add a little bit to our chart just to say that I've checked and repositioned their elbows slightly. So I'll just have a little look, same time as looking in the prone view, just perhaps move the elbow slightly just to change the pressure distribution on it for high-risk patients. A brachial plexus injury, these are traditionally described as tractional compression injuries in kind of non-cardiac surgery. Key thing for these is to avoid shoulder abduction more than 90 degrees. So if we're in that cruciform position, shoulder abduction be kept to a minimum just to allow the surgeons to get access to the abdomen. If the arms are on an arm board out on that cruciform, you want them either level or above the torso. You don't have shoulder extension where they're below. Both of those things, extension and abduction, just cause stretch and compression of the brachial plexus is kind of exiting the costoclavicular kind of junction. We want the neck in a neutral position. And then we're trying to avoid shoulder bolsters, which are largely historical. You won't see shoulder bolsters anymore. But we do sometimes put strapping over the shoulders as part of positioning for Trendelenburg sort of procedures, which can often go on for a long time. We always just check that strapping is not going to anchor the patient in some way to cause stretch over the plexus in the particular fossa. Again, just documenting if you are in a high risk position, intermittent acknowledgement that you've checked their position, that the arms are still on the arm boards and haven't fallen off, or the arm boards haven't moved, which they commonly actually do. Very useful. We're going to wrap things up, just final 2 minutes or so on NAP8. Lots of organisations involved. The fundamental purpose of all of these NAP projects is, of course, to improve the way that we're able to discuss anaesthesia with patients and maybe to update things like this information leaflet about some of the risks I've been talking about. So it's going to look at major complications of regional anaesthesia, both peripheral nerve blocks and neuraxial. So it's the first NAP that's going to rerun previous NAP project, NAP3, which is obviously 15 years ago now. Because you can't really you need to contextualize a risk of nerve injury with peripheral nerve blockade alongside a risk of nerve injury, general anesthesia, so that you can have an informed discussion with patients. So it is going to look at neurological injury and position-related nerve injury under GA as well. And this is the kind of headline flow chart, which I think is on the Royal College website. If you're, as always with the NAPs, if you're under the care of an anaesthetist, so importantly, it won't be looking at nerve blocks formed by our emergency medicine colleagues, although there is likely to be a separate project looking at that in the next year or two. If you're under the care of an anaesthetist and you've suffered harm as a result of either, on the left-hand side here, regional anaesthesia or local anaesthetic infiltration, then you will report. And similarly, if you haven't performed a regional technique, but there is a suspicion of perioperative nerve injury, of which positioning may be one of the causes, then you would report. Of course, the LEA, the local infiltration analgesia, that was added in part in response to, of course, the death of LEA in an independent. What sort of harms will it be looking at? Because it's not just looking at nerve injury, looking at an awful lot, and that's a real challenge to carefully define what we mean by some of these complications and encourage people to report them. So it's not just about peripheral nerve injury or kind of epidural hematomas. You can see some of those complications, some of those harms may occur with either a neuraxial block or a peripheral nerve block, so wrong route drug error, anaesthetic toxicity. Others are obviously specific either to central or peripheral nerve blocks. Then we've got the GA category. And the NAP's just going to follow, I guess, what has become sort of standard for the last few NAPs here, where there will be a baseline survey. So that will be asking all of us as clinicians to provide the NAP team with some information about our practice relating to regional anaesthesia and GAs and nerve injuries and other complications, what training we've had, how many blocks we do a year. If we don't do any blocks, because we're not an anaesthetist that does them, that's the baseline survey. And then there's the departmental survey, where institutions will submit kind of data about their institutional processes and organisation for nerve blockade, regional anaesthesia. Then the case reporting phase, which is often called the registry phase, 12 months, where NAP will want all individual clinicians and local coordinators to submit forms and log cases that suffer the harms that I showed on that previous slide. And then there's that activity survey part, which is to calculate the denominator data. Each organisation will put in 2 or 3 days worth of data for all activity at that trust. And each of those is going to run in 2026 and into 2027. So the baseline surveys that we will all be asked to fill out will be coming out at the end of 2025, beginning of 2026. An activity survey of denominator data will be into 2026. The case registry, that period where we're looking for submission of complications, will begin in sort of spring 2026. Those are the rough timelines. And of course, as I mentioned, the challenge obviously is that we don't hear about these complications in a very reliable way. They may come back to us eventually as individual anaesthetists, but often via all sorts of other routes. And that's, a real challenge for local implementation and trying to submit good data to NAP. Luckily, we've got our 2 best colleagues on the case. So I think Ollie Morgan and Dave Levy assisted with NAP7 and potentially other colleagues as well to act as local coordinators, try and help formulate ways that we can make good data to the NAP team. That was a very quick run through of nerve injury under peripheral nerve blockade, a bit on position-related nerve injury, and then a little bit on NAP8. But as I say, I defer to Ian on NAP8 and Nigel on the nerve injury side. Very much done.